think that's fine.
So I think we can start. Is it?
Yes, ma'am. I just need 1 minute to go live.
Yeah. So we invite Dr. Jaideep also.
Ma'am, we are live now.
Right. So
Now we'll start and do the invocation video and then hand over to Jaideep.
Okay, ma'am. Shall I start?
yes.
A very good evening, respected faculties. Today we are present here for our Core Connect live webinar on Knowledge, Aptitude and Practice series on breast cancer screening, the evidence. It is sponsored by Corona Remedies. Before going ahead for the introduction of all our dignitaries, let's start with a small prayer.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Now, I would like to introduce our moderator, Dr. Neeja Gupta. Dr. Neeja Gupta is a breast oncologist and oncoplastic surgeon in Delhi. She has done MCH in breast oncoplasty from University of East Anglia, UK, breast robotics from IEO Milan, Italy, observationship in breast oncology at IEO Milan, Italy, and MS General Surgery from Medical College, Baroda. She is presently working as a visiting consultant surgical oncology at Akash Healthcare, Dwarka, Dharamshila Narayan Specialty Hospital, Apollo Spectra, Karol Bagh, Delhi. She has many international memberships such as BRASA, ASOMA, EUSOMA, and OPBC. Welcome, ma'am. Now, I would like to hand over the session to you.
Thank you so much, Bhavna. And can I just share my screen right now?
Sure.
Sure. I'd like to welcome Dr. Sneha. Dr. Sneha Buyar doesn't need an introduction. She is well known. She is a well-known person with, she's been a FOXY breast committee chairperson in 1921 year. Then following that, she has been associated with AMOGS as a chair, and she's been working with the group member as a founder president with ISOPA. And she's done with a lot of awards which are there to her credit, with International Signature Award for the Leadership Award in 2020, and a National Award for Outstanding Work in the Rural Obstetrics. So, and there are many more to her. I welcome Dr. Sneha. Dr. Sneha, please, over to you. And please do the honors of inviting the guests for today.
Yes. Thank you so much. Thank you. A very good evening, respected dignitaries. And with the prayer, I'm sure we are blessed. And I am very honored and privileged to have you all here today for this program, which is, so very close to my heart. As I welcome Dr. Jaideep Tang, who is the president-elect of FOXY, and Dr. Milin Shah, who is the vice president of FOXY. And we do have some luminaries we are joining here now. Dr. Sampath Kumar, who is the Vice President of FOXI, and Madam Yashodhara Pradeep, they are joining soon. Sampath Kumari and Yashodhara Pradeep, they are at the Bharat Yatra in the South India. Today, I think they are at Vijayawada. So they will take little longer to join. I welcome my dear friend, Dr. Archana Verma, who is the past Vice President of FOXI. And I invite and welcome all the speaker for today's program, Dr. Gauravi Mishra, who has worked extensively in this field, and she has come up with a huge data which she has personally analyzed after her studies regarding breast cancer screening. So we will be very happy to listen to you, Dr. Gauravi. I welcome all the faculties, chairpersons, and of course, my mentor, Dr. Suchitra Pandit, who is trying to join and will be in a minute here. So I welcome all of them, just not to miss the time we just started with the program. So I welcome all of you dignitaries and the attendees, and I'm sure this program is going to be very helpful. I invite Dr. Jaideep Chand, who is the President-elect and Chief Guest for today's program. I know all of you know Jaideep as a very illustrious person and a very good orator. I would say any subject he will be speaking in depth and very in depth of the subject, and also stressing few points which are really very helpful for all of us. He was the Secretary General of FOXI. He was a project leader of FOXI USAID projects, and he's the immediate past Deputy Secretary and now the committee chair of IGA Committee AOFOG, and he has so many awards and accolades to his credit. So without much ado, I would request Jaideep to speak about this program and of course bless us, I would say. Thank you so much, Madam Suchitra Pandit. I welcome you, and over to you, Jaideep, for your precious words.
Thank you. Thank you very much, Sneha. It's a pleasure and privilege to be here. And let me begin by thanking and congratulating Dr. Sneha Bhuyar. Sneha and me worked together a lot in the COVID times, before and after. And I have always been very impressed with her extreme dedication and hard work for all the activities that she takes on. And Sneha, I wish you the very best in the forthcoming FOXI elections. I'm also very happy to be a part of this webinar, Sneha, where the guests of honor are Dr. Yashodhara Pradeep, Sampath Kumari, and of course, the chief guest with me is Dr. P.K. Shah. Dr. P.K. Shah was my teacher and indeed my examiner when I appeared for my third MBBS exam. And I always joke that I'm very happy that he's not regretted passing me in the MBBS exam at that time. Let me acknowledge the ICOG office bearers, Dr. Shrikhande, Dr. Ashok Kumar, the AMOGS office bearers, Pardesi Sir, Andita, Dr. Sujata, Kiran, and of course yourselves there. And you're such illustrious chairpersons, and you can see how dedicated they are because they are already here. There is my dear friend Milind, Dr. Suchitra Pandit, who I've always looked upon as a friend, a mentor, and a guide. Hi, Suchitra. It's good to see you after a while. And of course, the byword for enthusiasm in FOXI, Dr. Archana Verma. I've always called her the recharge battery of FOXI. And she's got quite quite a great thing for public awareness activities. I'm also very happy to see Dr. Gauravi Mishra, who's going to present a 20-year result of a study on clinical breast examination, a really vital topic. Thank you, Dr. Gauravi, for being a part of this. And of course, your moderator is Dr. Neerja Gupta, another very eminent oncologist. So congratulations, Sneha, on this program. I think it's a very important, very relevant program, and you have the best persons to enlighten the audience with. Thank you very much for having me.
Thank you so much, Jaideep. Dr. P.K. Shah, sir. Yeah, Dr. P.K. Shah, sir, who is the chief guest. Unfortunately, we couldn't have him today because he's stuck up with the orthopedic surgeon just now. So if at all the guest of honor, Dr. Sampath Kumari ma'am and Yashodhara Pradeep, they join, we will have their words of wisdom because they are busy in a CME at Vijayawada. So looking forward for all the blessings also. And over to you, Dr. Nirja, for the further proceedings.
Thank you, Dr. Sneha. So to kickstart the program, I would like to highlight the talks for today. We'll be having a talk by Dr. Sneha, which will be basically on the judicious use of the tools of screening in early detection of breast cancer. And the second speaker for today is Dr. Gauravi Mishra. Let me introduce Dr. Gauravi. She is professor and physician with Tata Memorial Hospital, Mumbai, in the Department of Preventive Oncology and Center for Cancer Epidemiology. And she is the core person who has been associated with the study of Tata, which is the single largest study on screening of Indian women in the rural population using clinical breast examination. Dr. Gauravi is the professor there in the Department of Preventive Oncology, and she also is a meritorious person with her very highly, an illustrious career associated with her. And the chairpersons for today, Dr. Milan. Dr. Milan is he's the president with ISOPAB, and he's the president with IMA Solapur, associated with the Infertility Center at Solapur, and has been doing very great and honored work since decades together, has been an active member with FOXY and other committees and has contributed a lot towards the same. Welcome, Dr. Milan, sir. And then Dr. Archana Verma, whom I'm already introduced to her a couple of years back. She's a great person, very charming. And whenever I speak to her, and she's always booming with Dr. Jaideep was right in saying she is the fuel tank. So she's always smiling and she's a very cheerful lady. So I have known her for the past about couple of years. So she's a vice president FOXY and has been an associate member of RCOG, with the founder president of the UP chapter. And she's been working a lot, creating awareness on women's health. Welcome, Dr. Archana. Really glad to have you here. And let me introduce Professor Chitra. Professor Chitra Pandit is the chairperson with the RCOG again, and president with ISOPAB, and associated as president with other societies in Mumbai and places. And Dr. Suchitra is she's very experienced, and she's
Yes, thank you, Dr. Nirja. In fact, I would take the pleasure of introducing Madam, who is my mentor and advisor. And Madam is the past president of FOXY as well as National ISOPA. And Madam is the present, she had just handed over to Dr. Alpesh Gandhi as president of, Justice India chapter. And of course, she's a very illustrious person with a highly decorated CV. Other than so many awards, I would just acknowledge only one award, the FICO Women Achievers Award, which is so very commendable. And Madam has lots of awards and accolades to her credit, and so much research oriented she is, I would say, and very instrumental in making the GCPR's guidelines and protocols. So with this, I hand over the mic to the chairpersons. I welcome you, Madam Suchitra Pandit.
So over to you, Dr. Okay.
Yeah, I welcome Millie, Archana, and Madam Suchitra.
Yes, thank you very much, Sneha, for this invite, and it's indeed a pleasure because we always feel that the breast examination, identifying the breast cancer at the early stages, is utmost actually important thing in the woman's life, because we have seen the spectrum of actually all those breast cancer problems. And that's why it's indeed pleasure to be part of this particular very well organized webinar. And I'm so happy that, we have such a wonderful team here to guide us on these various topics, especially this screening, actually the methods, And also we are actually very eager to understand this data actually study of last 20 years about the early screening by Gauravi. And Sneha, we want to learn from you that what actually you actually had done for your committee as well while dealing with the breast diseases. Yeah. I'm so happy to meet my very old friend Jaideep after a long time because yes, he's now quite busy with his future year of organizing various events, and naturally he need to prepare himself for his coming presidential year. I know Dr. Pikesha could not come, but yes, definitely will join. And Dr. Suchitra and Dr. Archana, yes, they are my co-chairpersons. I'm very sure that they are also they must have joined. Are they are actually in this group because I could not see them. Suchitra, you are there?
Course I'm there.
Uh, yeah, you are there. Achha, good, good, great. Yeah.
I'm not
So,
Mr.
friends,
India.
with this. Hi. So with this, now let us start with this first talk by Dr. Sneha Bhuyan. Sneha, your introduction has been
Yes,
given, so should we give it again?
it's okay. You can give it as remarks after the talk. Should I start?
Yeah, that's true. But before that, one thing I wanted to tell
Yes,
you,
please.
to tell the audience about Sneha. Friends, when I was president of ISOPAP, we just thought of, starting the Vidarbha ISOPAP chapter. And you got to believe in the span of 1 month, she could gather 100 members, and that chapter became so vibrant. That is the organizational skill of you, Sneha, and I'm so proud of you because of that. Because it gave a good actually impression, and so many people now got interested in the ISOPAP actually as an organization. So definitely, I wish you all the best for your coming venture as well. I'm sure that you are going to have a easy walking for your candidature, and I wish you all the best. With this, I request you to please start with your talk. Thank you.
Thank you so much, chairpersons, and all of them, my mentors. And yes, I take this opportunity to start with, from the basics, because we obstetrician gynecologists do not think that breast is our organ, or rather breast is our domain. And that's the very reason we start this talk or this topic with what is breast cancer. It's the malignancy of the breast. And of course, it can arise in the glandular portion, in the ductal portion. It can arise in the stroma as well. And you have a very high incidence of breast cancer. If you look at the statistics of 2018, it is 27% for the women per se, though it is 14% as a combined. So the incidence definitely increases with the age of the woman. As we always say, that being a woman itself is a high risk factor, but the incidence increases with age, and definitely after 40, it increases significantly. And that is why all the guidelines say that you should start screening after the age of 40. You can see here the incidence is 1 out of 1681 by the age of 20, and it is almost 1 out of 69 at the age of 40. So that high, the incidence suddenly rises after 40. And what is the overview of these cancers? I would say breast cancer is one of the two leading causes of deaths in women, not only in India, but globally. And previously, cervical cancer was the #1 killer. But because of the effective vaccination, the very well-organized screening programs, the early detection and effective management, it has taken a seat back, though it has not decreased to a very significant level. Breast cancer is becoming #1 killer nowadays because of the lack of awareness, the social and cultural taboos, lack of organized screening strategies, and of course,
Neha, can I just interrupt, Sneha?
Yeah.
Do a screen share, do a full screen.
Yeah. Thank you,
Yes, ma'am.
So even the effective referral system is lacking here. So to accomplish this, as an obstetrician and gynecologist, I would say that we are the ones where we tackle all the problems of the women related to breast, right from early adolescence to, the childbearing age group and even later. So whatever problems related to the reproductive organs and breast, they're tackled by the obstetrician gynecologist. So by virtue of their practice, we are well versed with the benign breast diseases and also directly concerned with the breastfeeding promotion and the problems associated. At the same time, the endocrinological problems like mastalgia, galactorrhea, and also the problems associated with menopausal hormone therapy and follow with the hormone therapy for breast cancer, we take care as a whole. So to accomplish this, the American Board of Obstetrician and Gynecologists has provided guidelines to integrate this basic training of the breast diseases in postgraduate curriculum. And I'm sure you will all agree to me that this is also not seen in India, and we too need to undergo such training or maybe the changes in our curriculum. So we have to treat breast as our domain as far as the breastfeeding, benign breast diseases, and making awareness, screening, and early detection of breast cancer. So we have to play a role of, preventive oncologists. So this is just to understand, this is the anatomy of the breast, the side view. This is the milk secreting glands, and these are the white ones, tubular structures, the milk collecting ductules or ducts, which carries the milk towards the nipple. So here, this is the lymphatic system of the breast, and you have various lymph nodes which are of clinical importance, because these are important as far as the staging, diagnosis, and management is concerned. So the high, mid, and low axillary, and also the internal mammary and supraclavicular lymph node, these are very important. These are the hormones which are the culprit, actually the same hormones which are responsible for the feminine development of the woman, same hormone are the culprit for the growth of the breast cancer. And so we divide the breast screening into three parts. One is risk screening, second is breast screening, and third is genetic screening. So breast cancer is one of the two major causes of the deaths of women, and it accounts for almost 14% of all malignancies, cervix, lung, colon being the next. So over last 2 decades, the picture has changed significantly. That is what the situation is now. So what the message we have to deliver here, it is not a disease per se having a breast cancer that leads to mortality, but the late diagnosis and the complications associated or the morbidity associated leading to death, that is a problem here. So in India, the number of cases may be less comparatively, but the mortality is high as against the Western world, where the cases are more, but the mortality is less, because 70% of the cases are diagnosed in advanced stage in India. So the survival rate post-cancer treatment is 60% in India as compared to 80% in US. So screening and early detection, timely and effective referral for appropriate management, these are the only effective strategies to reduce the mortality for breast cancer. So though we say till the cancer is not curable, only choriocarcinoma and early breast cancer, they are curable if timely and appropriately treated. So screening plays a very important role, and that is why we are here to discuss these screening modalities. So screening test should be, it should be very highly sensitive, not to miss anything, but it should be highly specific at the same time to avoid large number of false positives. It should be easily acceptable, accessible, and preferably non-invasive. It should be cost effective as well. So self breast examination and clinical breast examination on priority, and then the various imaging modalities we have to incorporate to go for the screening. So we have this modifiable and non-modifiable risk factors for breast cancer. Non-modifiable, as you all know, that being a woman, her advancing age, her family history, personal history of having one breast cancer earlier, she puts it on higher risk of having the second one. Early menarche, late menopause, the greater estrogen exposure, increased breast density, chest irradiation in the childhood, and BRCA1, BRCA2 mutation positive. These are the non-modifiable risk factors, but modifiable ones are very important for us because we can work on it. Obesity, alcohol, smoking, menopausal hormone therapy, combined OC pills, age at first child, and the breastfeeding practices. All of these are the risk factors where we can work. Definitely, we can guide the patient and try to minimize. Coming to the breast screening, when should we start screening the breast? The various organizations, including United States Preventive Services Task Force, American Cancer Society, ACOG, American College, the American College of Physicians, and American Association of Family Physicians, all of them unanimously agree that for an average risk woman, at less than 40 years, the screening is not required, and it is recommended only after 40 years. How it varies in different organizations, but most accepted and popular screening guidelines are ACS guidelines, where it says that for an average risk woman, the screening should start after 40 years of age. It should be mammography annually. But I mean, you can give the option of self breast examination after the age of 20 years. And for a high risk woman, it should be mammography and MRI done at the, at least at the age of 30 years, or maybe 5 years earlier than her relative who was diagnosed as having breast cancer. And it should be, repeated annually. So coming to the various complaints and signs. So the symptoms, which can be the asymmetry in the shape and size of the breast, there can be lumps and bumps, there can be dimples, there can be changes in the color of the skin, discoloration, the erosion, nipple inversion. All these changes should be noticed by the woman. When she should carry out the self breast examination, she has to do it every monthly, and it has to be done in a week after the menses. So post-menstrual periods, and it should be done with a specific technique, which how she has to stand, how she has to stand in front of the mirror, she has to expose herself up to the waist, and she has to examine her in a standing position with her hands by the side first, then raised above the head, and then of course on the waist. So all these three positions she has to look for all these changes. And even though the evidence doesn't suggest any reduction in the mortality related to breast cancer because of self breast examination, it increases. I mean, for a resource poor country like India, it at least helps us, our women, to make it breast aware, so that they can examine their breast. Though for developed countries, it says, the statistics says that it doesn't help in reduction in the mortality. Where women neglect all these changes, we have to actually tell them that they have to examine. So initially you have inspection for all this, and then she has to palpate her breast. I think the slide is missing here. So she has to palpate her breast, maybe in lying down position or again in the standing position, and she has to do this with the palmar aspect of her three fingers firmly pressed, and she has to deeply palpate right from upside down, side to side, may it be concentric or radial. The idea only is being to not to miss any part of the breast. This is what is about self breast examination. Of course, the last point is to see for any breast secretion. Same examination, if done by a clinician without using any gazette, then we label it as clinical breast examination. Now we come to the breast imaging modalities, where you have various modalities. So the mammography being the gold standard of this imaging techniques. And of course, you have various types of ultrasound, right from sonography, automatic breast ultrasound, contrast enhanced ultrasound, three-dimensional ultrasound, color Doppler, power Doppler, tissue electricity imaging, elasticity imaging, stress elastography, shear wave elastography, and then even for this MRI, you can use it. Magnetic resonance imaging, also you can incorporate diffusion wave imaging, magnetic resonance elastography, magnetic resonance spectroscopy, and of course you have the gamma radiation, nuclear medicine. This is just to complete the list of whatever imaging modalities available. So gamma radiation, nuclear medicine with a single photon emission, that is the PET, single photon emission computed tomography, the SPECT, and positron emission tomography, the PET. Non-ionizing radiation in the form of optical imaging and breast microwave imaging. So all the modalities of imaging available. When we have to do this, there is a recommendation that from the age of 40 years, you should offer her the option for go for mammography. But if not, 45 to 54, we have to recommend it or make it mandatory for mammography. 45 to 54, if everything is normal, then, of course, 55 years onwards, you may just taper it down to every 2 yearly and continue up to 70 years where you have the plateau of the incidence of breast cancer, or maybe when the life expectancy is less than 10 years. So 40 years, you have to offer her. 45 to 54, it should be mandatory. And if everything is normal, there's no abnormality, then 55 years onwards, you have to taper it down to every 2 yearly and stop it at the age of 70 years. So mammographic signs of breast cancer can be very subtle. You have to evaluate positioning, you have to maintain a standard of search pattern, and of course, compare current mammogram to the prior ones. So that is how the various images, you have to maintain the search pattern when viewing the mammograms. You have to be always very carefully assess the fat glandular tissue margins, both the posteriorly and anteriorly, and of course the contour abnormalities. Here in this picture, the mammogram show a subtle focal asymmetry here, the circle which is shown here, and in a patient where you have the scattered fibroglandular tissue and a contour deformity with a new anterior convexity. This is a magnified area of interest from CC and DPT image shows a subtle architectural distortion. So even though we have these images, we leave it to the imaging person to opine about this. I just give you a table where what procedure or what imaging modality has higher specificity and sensitivity. So for us to remember, mammography is the gold standard for screening as well as diagnosis. The specific sensitivity is 68.3% to 83%, and the specificity 90 to 95% almost. Of course, here you have full field digital mammography, contrast enhanced mammography that improves the sensitivity even for the dense breast. And of course, the 3D picture visualization soft copy can be available, and it can be viewed when necessary. It can be shared for the telemedicine also. These are certain advantages of this procedure. Breast symptomammograph, when you injection of the TC99N systemic images by the gamma camera, it gives you very high sensitivity comparable to MRI, and it gives you very high cancer cells uptake of the drugs. So if you have a suspicious or equivocal lesion on mammography, this is one modality where you can use for differentiation. And of course, the breast ultrasonography, what we label it as conventional sonomammography, is now coming up very high. And of course, it increases the sensitivity to almost 95%. Of course, it gives you high false positive result. We have various modalities compared here. Volume-based ultrasound, which gives you the sensitivity of 97.67% and also the specificity of 99.7%, especially in cases where you have dense breast, the high risk women, especially when on simple digital mammo you have BIRATS 3, then this is the investigation which will help you out. PET-CT is also a good screening technique. Considering all the pros and cons, we come to the conclusion that digital full-field mammography is the best method available. I would just say mammography is the best, or rather the gold standard for screening. Ultrasound, it's only for younger age women who have dense breast and where it is difficult. So here you can just club or combine the mammography and sonography to come to the conclusion where you cannot come to the conclusion by mammography alone. Especially the ultrasound gives you details of morphology, orientation, and the internal structure. So adding ultrasound to mammography improves your sensitivity to more than 97% and specificity also. Also, it can guide you for the biopsy. Ultrasound, you have various types of ultrasound. I have already said about this. MRI, only for high risk women, to be started after 30 years of age and repeated annually. Of course, if it is very high risk, you may repeat it every 6 monthly. But for a routine average or average risk women, it is not recommended as a routine. Only when both the sonography and mammography both are inconclusive, in such situations you may have to go for MRI. MRI also, you have various this diffusion weight imaging, magnetic resonance, elastography, and spectroscopy, as we have talked about. So increased sensitivity in these patients with dense breast and postmenopausal and very young women at the extremes of age. Sensitivity with full-field digital mammography was approximately 70%. These are just the findings which actually included to compare both these, both these methods of modalities of imaging. And this is about tomosynthesis, that elimination of the overlapping structure and shadows as variable slices can be seen here. Better visualization of the dense breast tissue, that is one more advantage with tomosynthesis. Clearer margins of the lesions, it reduces our callbacks. Also, visualization of finer details can be done, and the dose from doing this projection image is similar to the single view mammograph, but there are multiple tomographic images. So these are certain flaws of this test. Now, when to offer the genetic screening? So just because she's got cancer, breast cancer, she needs genetic screening, that's a myth. So genetic testing for breast cancer has got specific indications, and I would say only in short, breast cancer in women less than 50 years of age, or the one having breast cancer less than 60 years of age with one of the relative having either CA colon or pancreatic cancer, and male relative having breast cancer, and of course breast cancer in a woman who is less than 60 years but triple negative. So these are the women who they are high risk, and they are the ones who need the genetic screening. So I would say self breast examination, which makes a woman very aware about their own breast. As and when needed, or they detect any abnormality, they have to report to their physician or gynecologist and should get the clinical examination done. And of course, the clinician should subject the woman for necessary and appropriate investigations. If at all there is a suspicion, the confirmation has to be by tissue diagnosis. So core biopsy is the confirmatory tool for diagnosis. For us as gynecologists, I would just say we have got a role as preventive oncologists. So right from the healthy living, healthy eating, providing taking the right history from family history, medical history, and also subjecting her to appropriate investigations and helping her getting diagnosed at the earliest, and referring her timely to the appropriate person should be our role, and that is how we can take care of our women. So I urge here to all our obstetricians, gynecologists, all my dear friends, fellow Foxians, to make an habit or to utilize this opportunity to examine each and every woman as far as her breasts are concerned, whether she has any problem to her breast or no. This is the window of opportunity we have to utilize to examine the breast. If at all you find any abnormality, you subject her to investigation. If you don't find, you teach her self breast examination and ask her to report to you if at all they find any abnormality. So early detection saves lives, and not only lives, saves breast also. So that is how she can go for quality living in future also. And thank you, Dr. Neerja, for giving me this opportunity for speaking on this topic after a long time. Thank you once again. I thank you, Chairperson, Madam Suchitra Pandit, Dr. Milind Shaha, and Dr. Archana Verma. With your permission, I make an appeal for myself that I'm going for Foxy Vice President. I'm contesting for this post of Foxy Vice President for the year 2023 for West Zone. And I request your not only vote, but wholehearted support for my candidature. Thank you so much.
Well done, Sneha. You've always worked very, very hard for your committee, and it was important to create awareness about this is a relatively new committee in Foxy, and to get everybody to start thinking that now the breast belongs to the gynecologist, start looking at it, because
Oh,
the
yeah, okay, sir.
cancer is alarmingly high. And it's important, we talk to people about screening programs and everything. It's important. First thing is to be aware, and second thing is to bring to limelight what is the importance of mammography. So well done, you've covered up everything, and I'm sure as far as elections are going to go, everybody has to fight that election to win that particular position. So I'm sure that not just us, everybody else who is listening and all the people who have attended your programs know your worth, and they will definitely support you in large numbers. And all the best, Sneha. We are with you, and I'm sure you'll sail through. Thank you very much.
Thank you so much, madam. Thank you so much. Over to you, chairpersons, Archana, Dr. Archana Verma, whether you want to make any comments.
Yes. Thank you, Sneha. Really, this is, I'm really thankful and honored that you have invited me. Thanks to Nirja. And I have listened to all, and especially Dr. Jaideep Tang. He always takes and make it sure that he is doing A to Z. And Dr. Suchitra is one person I always dream of becoming like her. She's so much knowledgeable, such a great mentor, such a great teacher. And best part is she looks and feel and make everybody feel friendly and young. And that is required for all of us, with the patients also, and taking care of everything. Preventing the preventable is a long time needed, because in India we have to see the economical aspects also, and if we can do the proper screening, and this awareness of screening is really needed, when to go to a doctor and when to do things, and how to take care of a lifestyle and all the problems. And Sneha, among all the election candidates, I think you are so close to my heart that you know that, because you are the only person, I think, irrespective of chairpersons or vice president or president, who is working as Dr. Suchitra Pandit, my ideal, my God. Even she always talks positive, she always behaves positive, and her action speaks louder and louder. So that I want to say for everybody, and I want Sneha, that we want you and you will always never leave our hand, and you are such a great person. I remember Dr. Milinsha and Dr. Sneha, how they have taken care of me. They are my family. I think, though I belong to this place and that place, but I don't know, we ऐसा हम लगता है कि स्नेहा और मैं कुंभ के मेले में खोए हुए भाई हम लोग फैमिली में से हैं. So thank you everybody, and Nirja, especially Nirja, like she's the one person who is really expert in breast issues and problems and oncology, and we should always try to take expert opinion. This should be in our motto. Thank you, Sneha. You will definitely going to have a clean sweep victory.
Thank you so much, my dear. Thank you so much. Thanks for your special visit. Right? Yeah.
Suchi ma'am,
can I? Yeah.
Got freezed. I think network issues, madam. Yeah.
Ma'am,
yes, Dr. Milinsha, any comment?
Dr. Milinsha is busy.
Yeah.
So can I just?
No. I'm very much listening, and actually the talk given by Sneha is always mesmerizing. So only thing I was doing little multitasking. Yes.
Sneha, तुम्हारी talk जल्दी खत्म हो गई सही में. We were so much involved. ऐसा लग रहा था और सुनने और
Because we
सुनने
are eager to listen to Dr. Gauravi Mishra now.
Exactly.
Dr.
Knowledge
Gauri
is
ma'am.
Got a
And thank you,
extensive
Milinsha
work.
sir. Thank you. आपको अभी फिलहाल मेरी I am so lucky that I met Suchi madam and Milinsha also and missed meeting
Same here,
Sneha. And
Archana. Thank you
I
very
think in
much.
future I would love to meet Dr. Gauravi also.
Thank you so much. Thank you.
Thank you. Thank you.
Thank you, Madam Suchitra Pandit, and thanks, Dr. Medinsha.
So may I just have may I invite Dr. Gauravi? Dr. Gauravi, can you please take the stage, and please we are ready to listen to you. Actually, very eager to listen to you. Dr. Gauravi, you are muted.
Yeah.
Yeah.
So can you see my screen and can you hear me?
Yes.
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 Yeah. So good evening, everyone. And at the outset, let me thank all the organizers. I'm an outsider in your team, and I thank Dr. Nirja, Dr. Bhavna, Dr. Jaideep, Dr. Melin, Dr. Sneha, Dr. Suchitra, Dr. Archana, and my teacher, Dr. PK Shah. Though he's not there, he has been my teacher, like how Dr. Jaideep said, and he had also been my examiner in my third MBBS. So would have loved to have him here. And thank you, Dr. Sneha, for setting up that stage and really talking about all the risk factors and signs and symptoms, the preventive measures, the different modalities of screening, etc. That makes my job quite easy now. So basically, I'm going to present this study that we published in the British Medical Journal last year. And this is about clinical breast examination. The same what Dr. Sneha spoke about, physical examination of the breast. And we were the first ones to give the evidence globally that breast cancer mortality can be reduced by clinical breast examination. So it's not always that the evidence comes from the West. If we conduct good quality trials, from India, then we can give the evidence to the world. And this is what we did. And I'm going to describe this large trial that was actually initiated by Dr. Mitra in 1998. And from 2000 onwards, I managed this trial till the end of the study. Just to begin with, I think Dr. Sneha has put the perspective in place, but sharing this data from Globocan, I mean, if you look at the map, the color on this map on each country indicates the most common cancer in that particular country. And you can see that not only India, but nearly the entire globe appears pink. And that's the reason being that breast cancer is not just a common cancer in India, but you can see that it's the most common cancer in each and every country globally, except for few African countries where cervical cancer still remains the most common cancer, and in Australia where the melanomas and the skin cancers are the most common. So yes, it is the most common cancer, and if you look at low middle income countries, then they account for 2/3 of all the breast cancer, both incident and death cases. And yes, our major problem is that we see these cancers at really advanced stages. There's no real reason to do that. And of course, we have limited diagnostic and treatment facilities. Like what Dr. Sneha said, there are multiple modalities of screening or early detection of breast cancer, and she has nicely gone through the advantages, the sensitivity, specificity of each of these methods. But now what we need to understand is that someone walking into your screening clinic, you can offer them multiple modalities. You may offer a mammogram, you may offer breast self-examination, you may offer a clinical breast examination, you may have an eye breast scan. But what I'm here to talk about is the evidence that we gave for our National Cancer Control Program. So we do have a National Cancer Control Program since 1975. And since 2010, it has been integrated program as the NPCDCS program, that is National Program for the Prevention and Control of Diabetes, Stroke, Cancer, and Cardiovascular Diseases. They all have been put together because mainly the risk factors remain the same and the preventive modalities remain the same. So now, how do we decide when we want to really go for population-based screening as a part of our National Cancer Control Program? How do we choose the modality? Okay, should it be mammogram? Should it be breast self-examination? Should it be clinical breast examination? So how do we decide it? So this evidence comes from randomized control trial. Now, randomized control trials are huge trials which are really difficult to implement, which go on for 20-25 years, and then we really come to know whether this is a good screening tool and whether it's actually going to turn to reduction in mortality. Tomorrow, if I say that, a particular modality, with a particular modality, we can diagnose cancers at an earlier stage. Is it a good screening modality? Then there is a question mark. If finally, even if after detecting a cancer early, if you're not able to reduce the mortality due to that particular cancer, then it's not a good screening tool for the population level. So that is the reason that we need to have a very strong evidence, a level 1 evidence, which comes from a randomized control trial when we are looking at population-based screening. And that is the importance of this trial. Now, suppose we have a very good screening tool that is available with us. Suppose I say that, breast self-examination, we have, or clinical breast examination, it's such a good screening tool that you have a 100% sensitivity and 100% specificity. Of course, there is no screening tool in the world for any disease with that kind of a specificity or sensitivity. But suppose we have such a screening tool, will it ultimately reduce mortality due to that particular disease? Now that's the question that we need to understand when we are looking at population-based implementation. Herein, we need to understand that even if we have such a screening tool available with us, when we go to the population and when we invite the people to participate in our program, it's not that everyone is going to participate. Some will participate, some will not. So we will have a dropout at that level. Again, even if they come and participate in your program and they listen to a health awareness talk or something, not everyone is actually going to participate in your screening. And not everyone is going to give you a consent. And even if someone participates, again, there will be a dropout at that level. And then you're going to screen some people as positive and who are going to require further diagnostic investigations. Is everyone who is screened positive going to undergo that investigation? And is everyone who undergoes that investigation and is diagnosed as a cancer case going to initiate the treatment? And those who initiate the treatment, are they going to complete the entire modality of treatment? It may be surgery, radiotherapy, chemotherapy, followed by hormone therapy. And then even if they complete the treatment, are they going to come for regular follow-up? So then the success of the program is not determined just by having a good screening tool. Of course, that's a necessity of a screening program. But the success of the program also depends on the participation at each and every level. And then when we are talking about this, we need to first understand, which are the good screening tools at the population level and why so. Now, Dr. Sneha really nicely, she told about breast self-examination, and she also talked about the evidence for it. Just to revise, breast self-examination really appears to be something that is low cost, that we can teach our population, and that would be really low cost. That if taken up, it looks like the cancers would be detected at an earlier stage and it would help. This is what common people would think about it. But then two very large randomized controlled trials, one which was conducted at St. Petersburg in Russia, very large randomized trial, and the other at Shanghai in China. And again, these were the trials wherein the participants were actually nurses, which were educated, who understood how to do it. And, we thought that they're literate and they would participate and they would follow up with the instructions. And even after this, both the trials, categorically, when the results were analyzed after 15 years, after 20 years, both these trials concluded that breast self-examination did not reduce mortality due to breast cancers. So there is a level 1 evidence, not from one randomized trial, but from 2 trials, that breast self-examination does not lead to reduction in mortality due to breast cancers. So then BSc cannot be used as a screening tool for a public health program. But then do we not teach our population BSc? The answer is no, we need to teach them BSc, breast self-examination, for the reason that it would at least increase the awareness of the patient, of the women, about her own breast health. And supposing she finds some tumor, maybe she would come earlier, or she may approach a doctor. But can it be used as a screening tool for the population-based screening? The answer is no, because the evidence goes against it. What about ultrasonography? Ultrasonography, of course, there have been no large randomized controlled trials done, but we know that it is good for detection of cystic lesions, for detection of benign lesions of the breast, but it does not give a picture of the entire breast at a go, and it does not show any microcalcifications, and it's not used as a screening tool for early detection of breast cancers. Coming to mammography, we have evidence from 7 large randomized controlled trials, mainly from the Western world. And we know that the incidence of breast cancer is several fold higher in the Western countries. And they have really invested to find out what is the cause, how we can screen the population and prevent deaths due to breast cancer. And we have trials starting from 1963 till date, large randomized trials on mammography screening. And all these trials, they showed that yes, breast cancer mortality can be reduced by mammography, but the benefit is mainly for women who are above 50, because for women who are below 50, the breast, because they're premenopausal, the breast tissue density is more, and hence the breast cancer, small breast cancer, can be easily missed. So mammography has been shown to be a good screening tool for the early detection of breast cancer. And we have seen that if you do a meta-analysis, the mortality due to breast cancer is reduced by 15 to 20% when mammography is used. However, the Cochrane review, when it was all these trials were put together, there were nearly 6 lakh participants in this all the 7 trials.
We join karte the.
And when it was put together, we saw that if assuming that screening reduced mortality by breast cancer by 15% after 13 years of follow-up, there will be an over-diagnosis and over-treatment by 30%. What do we mean by over-treatment? It just shows that mammography will detect so many women who are stage 0 breast cancer. And again, we know that the stage 0 breast cancer, many of these women are really not going to progress to invasive cancer. But now, because you have detected a stage 0 breast cancer, you need to treat them. Ethically, it would be wrong not to treat them, because we don't know who is going to progress to invasive cancer. So then there is a 30% over treatment, because now you have diagnosed stage 0 breast cancer. Again, there will be at least 2,000 women who would be invited for screening through 10 years, and one will avoid dying of breast cancer. But there would be so many women who will be false positives. That among these 2,000 women, there will be at least 200 who are false positives, who will need to undergo additional investigations like biopsy and other things, and will cause a lot of anxiety. This doesn't mean that mammography is a bad screening tool. It means that it has to be used really judiciously for women who are above 50 years. And of course, in a clinic-based setting, for women above 50 years, we do offer a mammography-based screening. But then, when you're looking at population-based screening, and I'm not sure if people are joining from the district places for this particular webinar, but if you look at our country's situation, when we're talking about population-based screening, it means that the screening has to be done at the village level, because every woman has to be screened at least once in 2 years. That's what the evidence says. Now, if you look at our country, then we don't have a single mammography machine in every village. In fact, in none of the villages we would have a mammography. Even at taluka place, there are no mammographies. At a district place, few districts would have one mammography machine or something like that. In this scenario, we are not even equipped to conduct mammography-based screening. Secondly, we don't have so many radio technicians and so many radiologists to read the mammogram. So as such, for population-based screening, we are, even if mammography was one of the best screening tool, it is just not feasible for next couple of decades. It's beyond imagination. Now, of course, with mammography also, we need to repeat the screening every 24 months. And let me tell you that we do have a National Cancer Control Program. And if the latest survey that was conducted by the NFHS 5 survey, it shows that screening uptake or cancer screening is being availed by less than 2% of the eligible women. Less than 2%, that's the current status. So again, that's mammography and breast self-examination, sonography are out. So then we need to look at our own population, and we need to devise something for our own population. So coming to this, that we have seen that these are something that are not ideal screening tools, and because it's the most common cancer in India, breast cancer, we had to find our own solution. Western countries, they have a solution. They have chosen mammography screening for their population. So this entire trial, it was initiated in the year 1997 actually by a breast surgeon, Dr. Indranil Mitra. And this was basically started to investigate whether the efficacy of a well-planned cancer education program, giving a proper cancer education program provided by trained medical social workers, along with screening by clinical breast examination, which will be performed by trained primary health workers. Now, whether it will help in downstaging breast cancers, that is detecting breast cancers earlier, and whether it will finally go on for reducing mortality due to breast cancer. I mean, reducing mortality due to breast cancer is the final goal. If downstaging is achieved and mortality reduction is not achieved, that screening tool will not be helpful. Now, herein, we could have easily employed doctors in the field to conduct this examination in Mumbai, or trained nurses, but we did not do that. What we did was we employed 10 standard pass girls whom we taught how to perform clinical breast examination, and we gave intensive training for 3 months at Tata Memorial Hospital, and then saw whether they would act as primary health workers and conduct the screening. The reason for doing this was we could have employed someone over here who was highly educated, but then if we want to take this program to the villages and to our rural areas, then we needed someone who would be easily available at the village level also, and that is the reason we went for 10 standard pass girls to conduct this program. Now it was a very huge program, a huge trial, which had nearly 150,000 participants who were between 35 to 64 years of age. This trial was conducted in 20 slum clusters in Mumbai. 10 slum clusters were randomized to intervention arm and 10 to the control arm. So we had 75,000 women in the intervention arm and 75,000 women in the control arm. In the intervention arm, we gave the women very good health education program, followed by screening by clinical breast examination. And this was conducted at 2 yearly intervals for 4 times. And then after that, we continued to follow up these women by active surveillance, again at 2 yearly interval, 5 times, wherein we went again house to inquire whether any women has developed breast cancer or has there been any mortality due to breast cancer. Now in the control arm, we just gave health education program in the first round, and thereafter for 8 rounds, every 2 yearly, we again went to the women's house to inquire if she has developed breast cancer or has there been any death due to breast cancer. Everyone who was screened positive from the intervention arm and anyone who thought that she had any symptoms from the control arm, they could avail all the diagnostic facilities at Tata Memorial Hospital with the Project I-Card free of cost. And again, all the women who were diagnosed with cancer, they received completely free treatment at Tata Memorial Hospital free of cost. Again, we did not want to miss any women, and hence we also had our linkages established with the Bombay Cancer Registry and with the Mumbai Municipal death records. Now you can imagine conducting this study over a period of 20 years, wherein, in Mumbai, where there were slum clusters, there was so much redevelopment happening, and those slum clusters were replaced with big towers, and the women were shifted all over Mumbai to different localities, and we actually traced them back to the new addresses, and sometimes the shifting took place multiple times, and we went multiple times to their new addresses to find them, their new homes, because this was a very difficult task, meeting the local leaders, meeting the politicians in the area, meeting the builders, meeting the neighbors, and trying to find out the address, because attrition was something that was not acceptable for such a big trial. So this is the trial we completed. The first 8 years were for the screening round in the intervention arm, and the remaining years were for active surveillance. So such a big trial, of course, it requires a lot of staff. We had a staff of nearly 100 people, mainly the medical social workers and the primary health workers. So we recruited them for the trial. We gave them intensive training at the Tata Memorial Hospital about conducting clinical breast examination, delivering health education programs, conducting surveys, meeting the local leaders, etc. And after that, we selected 20 slum clusters, and then they were randomized to intervention and control arm. So in the area, when we went to the slum clusters, we identified places where we could hold temporarily the camps, because if the women have to travel far off distances for 10-15 minutes, then they would not come to the camp place. So we selected places which were easily available in the area, like a local leader's office, or a family practitioner's dispensary, or an Anganwadi, a Balwadi, a church, temple, whichever the community would lend us to conduct this program, because we wanted community participation in this program. We did not rent any camp place. It was given by the community after meeting the local leaders and explaining them the importance of the program. So this was our routine. Our social workers used to go door to door in the area and invite the women to the screening camp. They would accompany the women to the screening camp, and thereafter the women were registered at the screening camp. They were explained the entire program, they were registered at the camp, and then their socio-demographic risk factor history was noted, and then the women signed an informed consent form in the local language, which was also signed by a witness. Thereafter, she was given this project I-card, by which she could avail the facilities at Tata Memorial Hospital if she had any symptoms of breast. In fact, this was also a trial for cervical cancer screening, and we were the ones to give evidence regarding VIA-based screening for cervical cancer, which was published in the JNCI in 2013. So I will describe the breast part of the trial now. So with this I-card, she could come to Tata Memorial Hospital if she had any symptoms of breast or cervical cancer, or if she was screened positive in the trial. Though these were women from different clusters, 75,000 women in the screening arm, nearly 75,000 women in the control arm. But when we put all the data together regarding the socio-demographic and risk factor history, we can see that both the arms, they matched each other. So this shows that there was a very good randomization, though it was a cluster-based trial and not an individual randomization. Because for population-based screening, when you go about, it's very difficult to have an individual randomization. Normally, the randomization is done by clusters. This was again a routine. After the women signed an informed consent form, health education program was delivered. And depending on, even if there were two ladies who were there at that time, the entire health education program was repeated. So our social workers, they delivered health education program before we took the women inside for screening. She was made to understand completely how she was going to be screened and what if she was screened positive. Our health workers, they examined the women by clinical breast examination, and Dr. Sneha has nicely described the steps of clinical breast examination and BSc, and we followed the clockwise method. The women was examined both in the sitting position and then in the lying down position. Her axillary nodes were seen, and the supraclavicular nodes were also examined. Thereafter, every day we would have camps in at least 20 different places with different teams. So thereafter, any women who was screened positive according to predefined referral criteria were referred to Tata Memorial Hospital for further investigations. Now, herein we need to understand that it is not a clinical judgment by a health worker that, oh, I suspect, it may be positive. We need, in a public health program, we need to define what is screen positive. It may be different definition for different trials, but we need to have know exactly whom the health worker is going to refer as screen positive. That if she sees any one of this criteria, she would refer the women as screen positive. So this way, it was a very standardized. We tried to minimize the subjectivity and make it a standardized program. So in any of the camps, if the health worker found any of this signs or symptoms in the clinical findings in the women, she would refer that women to Tata Memorial Hospital as screen positive. Now, obviously, when the health workers are examining the women, internationally, people may doubt about what was the kind of quality that of the examinations that was conducted. And hence, we had a medical officer who would go visit any one of these 20 camps and re-examine all the women who were examined by the health worker. So 5% of all the women were re-examined by a trained medical officer. And we see here that the agreement between the findings noted by the health worker and by the medical officer are the tune of 99% with a kappa value of 0.76, which shows that there was an excellent agreement between the findings noted by the health worker and the physician. Coming to the results, if we look at the results, then as I said, you need to have participation at all levels, participation for the health education, for the examination, women who are screen positive coming for diagnostic workup at Tata Memorial Hospital, and those who are diagnosed as breast cancer initiating and completing the treatment. So this is what you see the compliance in round 1, round 2, round 3 and round 4 of the screening round. So on an average, 67% of the people, of the women, they participated in each of the screening round, and the screen positivity rate was 1.3%. That means if we examined 1,000 women, then 12 would be referred as screen positive. And compliance to referral, that is someone who was diagnosed as screen positive who required further investigation, the compliance was 76%. And till the end of screening round, we diagnosed 199 cases in the screening arm. Amongst these are the women who are absolutely normal. They did not know that they had any symptoms of the disease. And the attrition was really minimal. These are the main attrition is because of the death of women, or she had permanently shifted and to a village or somewhere. And despite all our efforts, we couldn't trace her. So you can see that the attrition has been really minimal, 0.5% to 0.8% between each of the screening round. And this is the compliance for the surveillance round in the intervention arm, that is round 5, 6, 7, 8, 9 for the intervention arm women, wherein we went door to door to inquire whether there was any women who was diagnosed with breast cancer or had died due to breast cancer. And these are the total number of cancers diagnosed in active surveillance round in the screening arm. Similarly, this is the compliance for active surveillance in the control arm. So we diagnosed 650, there were 655 women who were diagnosed with breast cancer in the control arm during the same time period. So coming to the overall participation, so out of the 75,000 women in the screening arm, there were only 5% women who did not participate in any of the 4 screening rounds, who just refused to participate. The rest 95% of the women participated at least once. So, and if you look at the how many participated once, only once, there were 17% women who participated only once, 18% participated twice, 26% 3 times, and 33% participated in all 4 screening rounds. So, and all of them who 98% of the women in the screening arm and nearly the same in the control arm initiated the treatment and continued with the treatment. So again, as I said in the beginning, compliance at each and every level is very important in order for the trial to be successful, and it was a very strict monitoring. At the end of the screening round, that is at the end of the first 8 years, we had more cancers actually in the screening round than in the control arm. So we had 199 cancers in the screening arm and 152 in the control arm. There are more cancers in the screening arm because these are the cancers that are picked up early because of our screening efforts. And at the end of 20 years, what we saw was that there were 641 cancers in the screening arm and 655 in the control arm. And this crossover, it took place very late after 16 years, wherein the control arm cancers, actually these were the cancers who were diagnosed late and who were picked up late. So we had more cancers in the control arm at the end of 20 years, and at the end of 20 years there were fewer cancers in the screening arm. Coming to the staging of breast cancers, at the end of 20 years you can see that 63% of the cancers in the screening arm are diagnosed in stage 1 and 2, whereas in the control arm 53% of the cancers are diagnosed in stage 1 and 2. And this difference is statistically significant. So it shows that yes, cancers were diagnosed at an earlier stage in the intervention arm as compared to the control arm with the help of clinical breast examination that was performed by primary health workers. That means screening by primary health workers helps in downstaging of breast cancers. This was our intermediate objective. Now, when we look at the distribution below 50 years, the women who were recruited at the time of recruitment whose age was below 50 years and whose age was above 50 years, we see that in both these cases there is downstaging. There is significant reduction, significantly early stage cancers diagnosed in the screening arm as compared to control arm, both among women who were less than 50 and in the age group above 50 years. Looking at the mean age of diagnosis, we can see here that the screening led to diagnosis of cancer at slightly earlier age among the women who were in the screening arm as compared to women in the control arm. So there was nearly 1.5 years earlier diagnosis of cancers in the screening arm because of clinical breast examination. And looking at all-cause mortality, that is women in the screening arm dying of any cause and in the control arm dying of any cause, we can see that there's a 5% reduction in all-cause deaths in the screening arm as compared to control arm at the end of 20 years. But then this difference is not statistically significant. When we look at the breast cancer mortality, this was our overall goal, whether a clinical breast examination would reduce mortality due to breast cancer. And if we look at all the age group of women between 35 to 65 years, then we see that yes, this is person year calculation of mortality, and we can see that there was 20.8 per 1 lakh was the mortality in screening arm and 24.6 was the mortality in the control arm. There is a 15% reduction in deaths in the intervention arm women as compared to the control arm women, but this difference is not statistically significant. That means clinical breast examination does not lead to reduction in the mortality in overall age group of all women. In women who were less than 50 years at the time of recruitment, again, though the mortality appears to be less in the screening arm as compared to the control arm, but it is not statistically significant at all. But when we look at women who are above 50 years, we can see that there is a 30% reduction in mortality, and this crossover, this red line is for control arm women, the blue line is for intervention arm women. This crossover took place at 6 years itself, and there is a significant 30% significant reduction in mortality among women who were recruited above 50 years. Again, as I told you earlier also, mammography also gives major benefit among women who are above 50 years. And the same thing we see in clinical breast examination, that the mortality reduction is mainly among women who are above 50 years of age, and there's a 30% reduction. The mortality in screening arm was 24 per 1 lakh women, and in the control arm it was 34 per 100,000 women. So then we concluded that yes, it is feasible to implement clinical breast examination at the community level, and it is also acceptable by the women, which is seen by very good participation rates. We could retain the cohort, and we could capture all the events. We saw that it is feasible for primary health workers to perform this test, and the agreement rate with the medical officers was very good. And we saw that we could detect these cancers earlier in the intervention arm as compared to the control arm. There was earlier diagnosis, at least 1.5 years earlier diagnosis of breast cancers in the screening arm. Downstaging was seen both in women who are above 50 and below 50. However, the mortality benefit was mainly for women who were above 50. And our trial shows that it is possible to implement this clinical breast examination at the population level, and this is what has now been integrated into our National Cancer Control Program. So would like to say that this is the largest trial globally and the first completed randomized control trial globally on breast cancer screening by clinical breast examination. And our study validates the efficacy of CB clinical breast examination as an alternative modality for breast cancer screening in low middle income countries. This trial has great potential to guide the breast cancer control policies, not only in India but worldwide. The findings of this trial are of great interest even to countries which are currently actually having mammography based screening programs, because the benefit is similar to that of mammography. And if we just calculate with the global statistics, then CB has the potential to save at least 15,000 lives in India every year and over 40,000 lives in low middle income countries. Of course, this trial required a huge team effort with a lot of funding support that was required. And if we know the R01 grant of NIH, which is a very competitive grant wherein any investigators from all over the world apply for this grant, and we got this grant for 5 consecutive times, and that is the reason that this trial is also much appreciated. We acknowledge many consultants who were on this trial, experts who gave their opinion and pitched in from time to time. We have lots of papers published from this trial, but one important paper that would be of interest to gynecologists is the effect of BI-based screening by primary health workers. And this was again evidence given by this trial, which had another arm of cervical cancer screening. I think I would end here, and if someone would like to discuss any other trials, then I would be happy to discuss it. If there are any questions, I would be very happy to take it up. Yeah.
Your efforts, they are truly lauded. I mean, huge applause for the work you people have done. And that was an excellent overview of the entire thing. And I could not think of anybody else talking on this, because you people were the main, the core team doing it, and you must have had all the hurdles in the bottom. One question I wanted to ask was the kind of training you did for the matriculation pass girls. So how it must be a very structured thing. So 3 months of rigorous training means the theories, practicals, everything went down to train them. I mean, how did you actually do it?
Yeah, so it involves a lot of systematic approach to the training and capacity building. We are actually the capacity building partners even for the National Cancer Control Program, and we have signed MOU with Maharashtra state government and doing capacity building for their staff and various state governments for that matter. So this is a very structured program involving not just theory part, but a lot of hands-on examinations on patients in the clinics and also at our different community-based outreach programs. There is quality evaluation from time to time. They need to undertake exams and look at the practical experience and the practical examinations also they need to clear before they go in. And it is not just about screening, it is a lot of about conducting the surveys, counseling for the screen positives, etc., which takes place in this. It's a structured program, yeah.
Right. So now over to the faculty. Any comments and questions? I have one question I'll post in the end. So over to the faculty, please. Hello.
Yeah.
Dr. Sneha.
Yes, I'm here. I'm very much here and I'm listening to.
Yes, I know. So anything you want to ask or even comment on?
In fact, I would just say that, this is a very, very systemic approach, what Dr. Gauravi has done, lots of efforts she had put in going for, I just always talk theoretically and, what are the hurdles in the screening programs, because we do not have the organized screening programs and we have only opportunistic screening, and socio-cultural taboos, the main hurdle. So she is very, carefully focused on it, and the way she has planned how her staff would go and sensitize, and how they will collect the women for screening, how they will sensitize them. So I'm really impressed, But this is, only few people doing this will not work. And I just hope we should take it as a movement forward. And I think that should work wonders for India, at least for the low resource countries, because unless you make them aware, they will not notice anything. And unless they don't notice anything, they will not come forward for clinical examination, which actually, all the evidence is saying that clinical examination gives you, the significant reduction in the mortality associated, which the self-breast examination doesn't give. That is what is the debate goes on always, that why not self-breast examination? Because it only increases the anxiety and unnecessary biopsies. That is what the argument going on. But I would say for a resource poor country like India, self-breast examination is the only way forward that takes the woman towards the clinician who will now do the clinical breast examination. That is how the early detection will be improved. And of course, the survival will be improved. So I think wonderfully carried out the study as such, wonderfully compiled data, and I appreciate it very much. But I think we should not stop at this point, and all of us should join hands. That is what I feel personally. Thank you so much, Mr. Gauravi. Yes.
So can we, as a, looking at the Indian scenario, because Indian population has got denser breast than the Western population, has been already stated in a lot of two studies. So can we, as a Indian screening program, offer once in 2 years mammogram after the age of 55? That is the question. I don't know, because when we don't get clear-cut answers on this, but yes, our population is not so breast aware. They don't come forward and they present in advanced stages. And all the more reason of having denser breast than the Western population. I don't know whether, because women are very apprehensive. So
I think the guidelines say that if when you start screening right from the age of 40 years and up to 55 years, if you do not find any significant findings,
then you should.
Then you start tapering it down to 2 years.
You can should.
Yeah. So it's not all of a sudden, you just recommend initially itself to screen yearly. So systematically, if everything is fine, then I think you have a chance to reduce it down to every 2 yearly. That is what I feel. I don't know what is your opinion, Dr. Gauri.
Yeah, it has been clearly stated that if when you're looking at individual screenings, I'm talking about our country scenario, and when you're looking at individual screening, there is enough evidence to say from all the level 1 evidence from all the randomized control trials that mammography screening is recommended for women from 50 years onwards every 2 yearly. Doing it 1 yearly doesn't really improve the efficacy as compared to the rest. So it is 2 yearly starting from 50 years of age. And below 50, of course, the guidelines say that between 40 to 50, the women needs to take a decision after she has been explained the risk and the harms. This is regarding the clinic-based screening. When it comes to population-based screening, for India, the operational guidelines of the NPCDCS program and the evidence that came from our trial clearly state that it is clinical-based examination for population-based screening. And again, that has to be conducted every 2 yearly, starting from the age of 35 years till 65 years.
Right. I think we had a very nice discussion. And thank you so much, Dr. Gauravi, for your time. We understand you had it's a total crunch for you, Dr. Sneha. So appreciate.
I would just share one point from my point of view, why, because I was very eager to listen to you, Dr. Gauravi, because I was also quite curious what the data says. So I suggested Dr. Nirja that, if I prepare a base for, what is screening and what are the modalities of screening available, what does the evidence talk about it. So it will be helpful for our Foxians. And of course, the data which you presented will support to it. So I think that's a way we should go for. That's what I thought about, and that's why the talk was placed before you. But it was wonderful listening to you, and I'm really happy for such an extensive study you presented here. Thank you so much.
And that was a pleasure meeting you all, Dr. Sneha, Dr. Gauravi. It was a real pleasure. So maybe we connect some other time to offline also. Thank you so much. I think, can we wind up now?
Yeah, so thank you. I would like to thank our chief guest for today's program. Even though Dr. P.K. Shah could not join, he conveyed his blessings and best wishes to our program. Even just before starting the program, he was at the doctor's clinic. And our chief guest for today's program, Dr. Jaideep Chand, where we were quite fortunate to listen to him for his words of wisdom. And we had such wonderful guests of honor who are actually busy simultaneously for the on-site CME in the South Zone, that is Vijayawada. So Dr. Sampath Kumari and Dr. Yashodhara Pradeep being on the dais, they could not join us. Otherwise, it could have been pleasure to have them also. And we had such wonderful learned chairpersons, Dr. Suchitra Pandit, who is the Foxy past president and president of so many organizations, and Dr. Milind Shah, who is the past vice president of Foxy and ISOPUB national president in past. So we really had learned people, and Dr. Archana, such a loving person who is also the past vice president of Foxy. So I thank all of them, and I thank especially Dr. Gauravi Mishra for presenting her wonderful work here. And I congratulate you for this work, and I wish my best to continue your good work here. And thanks, Dr. Nirja, for the wonderful moderation of the session. Thank you.
Always a pleasure. Always a pleasure.
Thank you, Bhavna, for the wonderful, flawless conduction of the program with no technical glitch.
Thank you so much. Take care. Good night.
Thank you.